Good evening, and thank you for joining the RLS Foundation's webinar titled Understanding RLS Augmentation, Causes, Symptoms, and Treatment Strategies. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. I did want to alert everyone on the program tonight that we are experiencing weather in the Austin area. So if we have a little pause or there might be a pause in the sound or anything, just bear with us as we work through all this. The RLS Foundation is using Zoom webinars for all webinar events. To ensure seamless webinar access, confirm that your Zoom app is up to date and current with the software. If you need help accessing the live webinar on your computer, call the number listed on your registration confirmation email for assistance. If you have any other questions, please email kaylee@rls.org. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. After the webinar, the recording will be available in our website's member portal section on the next business day. If you are not a foundation member and would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. The information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker tonight is Dr. Mark Buchfuhrer, also known as Dr. B, a consulting assistant professor at Stanford School of Medicine. He is a certified RLS expert and teaches sleep medicine to doctors training at Stanford Sleep Medicine Center RLS Clinic, a member of the RLS Foundation's Quality Care Center network. He also has a private practice in Downey, California. Dr. B is a board certified in sleep medicine, pulmonary disease, and internal medicine. Dr. B serves on the Foundation's Scientific and Medical Advisory Board, where he serves as the Foundation's chair of the Medical Bulletin Committee, the Opioids Committee, and the Revised Treatment Consensus Committee. He is also our medical editor of Nightwalkers. Thank you, Dr. B, for sharing your time and expertise with us today. I now invite you to begin your presentation.
Okay, thank you, Carla. And as everybody knows, we're going to be talking about augmentation, which is one of the biggest problems that we experts see when we're treating restless legs. And I'm going to go over everything, hopefully you ever wanted to know, and even a bunch of stuff that you didn't know you wanted to know about this augmentation. Forget the copyright here. So what is augmentation? Whoops, I think we got the slide in a little out of order here. Okay, we're somehow missing, I didn't see that there. Okay, so what the slide should have said there is that augmentation is a worsening of restless legs from taking a dopamine drug, which includes drugs like the Sinemet, Mirapex, Requip, and the Nupro patch. But it also occurs with tramadol, which is known as Ultram. That's a pain pill which is somewhat related to opioids. We're not really sure it's an opioid. It doesn't occur quite as commonly with this medication as it does with the dopamine drugs. And to get the augmentation, you really have to take the tramadol or even the other medications on a pretty well daily basis. The intermittent use does not cause the augmentation. Now, what you should know is this augmentation does not occur with the alpha-2 delta drugs. Those are the gabapentin-like drugs, Horizont, which is a better absorbed form of gabapentin, and pregabalin, or Lyrica. It does not occur with opioids, and it does not occur with the benzodiazepines. Now, when I mentioned the last two there, the opioids and the benzos, you can get tolerance of those medications, especially when they're used at higher doses. But the tolerance is different than the augmentation. All that happens with tolerance is the receptors become accustomed to the medication, so you need more medication to get the same effect. But these medications don't make the problem worse. They only you only need more medication to get the same effect. So it's different than the augmentation, although a tolerance-like phenomena can be part of the augmentation also. So when was augmentation first described? Richard Allen described it in 1996. So that's almost 30 years ago. He had a paper entitled Augmentation of Restless Leg Syndrome with carbidopa-levodopa, which is Sinemet. And he found that it occurred in 82% of the restless leg patients they were looking at. And it was worse with higher doses. And it was resolved by stopping or decreasing the medication. And what's amazing is, since this is almost 30 years ago, you would figure that the message had plenty of time to get across to practicing doctors. But this augmentation, and especially with the Sinemet or carbidopa-levodopa, clearly has not gotten very well permeated to the practicing doctors. I was just recounting a story that I saw a patient recently who had severe augmentation on the Sinemet, and the patient's doctor said to her, "Oh, you can just take the Sinemet just like you would M&Ms. Just take one whenever you feel you're having problems." And this patient was taking up to 25 per day and still being miserable. So we have criteria to diagnose it. There was NIH, National Institute of Health conference in 2003, and they came up with criteria, which is the ones that I still use. There are newer criteria called the Max Planck criteria that are quite a bit more complicated, and we use it for studies, but to be honest, practically I don't use it unless I'm involved in an RLS study. So the first thing is, it's a worsening of RLS symptoms after starting a DA dopamine agonist therapy or tramadol, and it can take months or years. The first thing that we see that really clues us in is an earlier onset. Patients will come in and say, "Oh, I didn't have restless legs until 9 or 10 in the evening or at bedtime." And after weeks or months on the medication, they say, "Now starting early evening, afternoon, sometimes even as soon as they get up in the morning," and that was not the case before treatment. You see an increase in the intensity of symptoms. They're just much more severe. Some of the symptoms, especially earlier in the day, may have not been hardly bothersome, and now they're just really intense. You see a quicker onset of symptoms with rest. Patients will say, I used to be able to watch a movie for an hour and a half and sit there comfortably, and before I got restless leg symptoms. Now, after 30 or 40 minutes, I got to get up and walk, and that wasn't the case prior to treatment. The other thing they notice that the medication effect doesn't last as long. Given medication may have lasted 6 or 8 or more hours, they'll find it only lasts 3 or 4 hours or even less. And the thing you see in a good percentage of patients is spread of symptoms to other body parts. The first place it goes are the hands or arms, but after that it can go to the torso and every body part. I've even seen several patients with RLS in their heads, which is really, really troublesome. And the last criteria is their periodic leg movements while they're awake. And only patients with restless legs have the periodic limb movements while awake. Many other people can have it while asleep, but awake is exclusive to restless leg patients, and it may occur for the first time or get a lot worse. And I've seen patients with bad augmentation who, when they wake up, their legs, with or without restless leg symptoms, their legs will just kick and prevent them from falling back asleep. So in the 2016 paper that we wrote on augmentation, we had a summary, a one-line summary, which is very simple. Whenever a patient who has been on stable treatment for at least 6 months requests medication, more medication, it's RLS unless proven otherwise. Now, there are some conditions that you should rule out before you call it augmentation. The first is if patients are on medications that can worsen restless legs. And these include a whole bunch of stuff, the older antihistamines like Benadryl, all the preparations like Tylenol PM have the Benadryl, over-the-counter sleeping pills, uh, a lot of the prescription anti-dizzy and anti-nausea pills, and of course, almost all the antidepressants will worsen restless legs. Low iron levels can, of course, cause a worsening without it being augmentation, and we always check, anytime a patient has any worsening for any reason, I always check iron levels again. Comorbid conditions. The big ones are pregnancy, usually third trimester, so hopefully that's pretty obvious. Renal failure, which usually is obvious, but sometimes can be missed, especially as they're not completely in renal failure and on dialysis. And of course, iron deficiency anemia, which is part of the previous point. But there is a huge list of comorbid conditions that have increased RLS. And I think one of the common denominators between all these comorbid or other conditions that are associated with restless legs are that they cause discomfort or pain, and anything that causes discomfort or pain will increase restless leg symptoms. Change in lifestyle. This is a pretty common one. It can be sometimes very subtle, but I'll give the example of a patient I had who was well controlled, and his work was a floor supervisor, and he'd been there for many years. He'd done such a good job, they gave him a promotion, and he had a desk job. And he came in and said, I don't know, my RLS just got worse. I don't know what's going on. We went into his lifestyle change, and he said, oh my God, I guess that's what it is. I'm sitting all day, and that's what's killing my restless legs. And I gave him a choice: stay in the job, add medication, or go back to being a floor supervisor. He went back to being a floor supervisor, and his RLS went back to where it was before. And the last is any increased stress, anxiety, depression. I see this all the time. I don't think a week goes by that I don't have a patient who has problems. They're going through a divorce, a move, health issues with a spouse, all kinds of things. And when that happens, that just ratchets up the restless leg. So you want to make sure you rule out all these issues. Okay, so one of the big things is it augmentation or a natural worsening of restless legs? And I think this is the issue that makes most of the doctors, general doctors, neurologists, and even sleep doctors who see restless legs and who are not at the very high level get confused and not realizing that their patient is undergoing augmentation, and they just say, hey, this is a natural worsening of the restless leg, so I'll just treat it with more medication. And it is very similar, but there are some differentiating points. So the augmentation gets worse with an increase in the dose. The trouble is, although this can happen sometimes in weeks or even a few months, it often takes months to several years. So it's easy for the doctor to say, well, you've been doing well for several months, many months or many years, so I guess it's just your disease getting worse, and I don't know why. I'll just give you more medication. But what the doctor has to do is look back at the increases in the doses. And if you see this pattern of RLS gets worse, you give more medication, it gets better, but then it keeps getting worse, and usually, not always, but usually the intervals of it getting worse get shorter and shorter. Some of the issues, of course, is patients may switch between doctors, and not every doctor looks back and gets the history of all the medication changes, and the patient may not even remember exactly when they were. But if you look at that, it's very easy to see, and you can realize it's augmentation. And again, if you follow the rule that I gave you before, if a patient's been stable for 6 months and asks for more medication, it's augmentation until proven otherwise. Now, the other thing that's interesting is the augmentation gets better with a decrease in the dose. So if you're giving any other medication that doesn't cause augmentation and you decrease the dose, the patient will get worse and they'll stay worse until you put back the medication. But what happens with levodopa, for example, the Sinemet, sometimes even within a few days of stopping it, the patient will get better. But it takes sometimes several weeks. It's often an average of 2 weeks with the regular dopamine agonists like Mirapex and Requip. And the problem is that the RLS gets dramatically worse until it gets better. So most patients will not be able to get through that period, especially if they're not warned about the mark worsening until they get better. So what do we think is going on and what is the cause? We're not 100% sure, but this is our best theory of what's happening. We know that the drugs that are working on the dopamine receptors, and there's 5 dopamine subreceptors, and the ones that we use, and you can see them listed, the pramipexole, which is Mirapex, ropinirole, which is Requip, and rotigotine, which is a Nupro patch. You can see they really work mostly on the D3 and D2 receptors. But you see at the very right at the end, there's the D1 and D5 receptors. And we believe that the D1 receptor is the problem here. It's not getting stimulated, and while it's not getting stimulated, the other dopamine receptors are getting stimulated. So it says, okay, I'm not getting much stimulation here, or not much drug binding to my receptor. So they do something called upregulate. They become much more sensitive because they're not getting much drug and they want to be able to respond. So by upregulating, they become sensitive even to small amounts that may bind. And we believe that that upregulation, which can take a while to occur, is what causes the worsening of restless legs, because unlike the other dopamine receptors, the D1 causes a worsening as opposed to helping restless legs. So the idea here is if we can block that D1 receptor from becoming active, we might be able to improve restless legs and be able to use those dopamine drugs. And in fact, Bill Ondo, who is in Texas, has published an early study with a drug called ecopipam, which blocks the D1 and D5 receptors, the two that don't get stimulated very well by the drugs we tend to use for restless legs. And this is the first study published a few years ago. He's still working on newer stuff on this. And this study was a small study, only 10 patients, and they were looking more at safety rather than effectiveness, although they did see some trend to effectiveness, but it was too small a study to say this is really effective. But we're hoping that this type of research might eventually enable us to use the dopamine agonists again in patients, especially who don't respond well to other drugs or don't do well with other drugs. So there is some hope in the future that we might be able to reconsider the dopamine agonist drugs as first line. So how common is augmentation? I already showed you with the Sinemet or carbidopa levodopa, 82%. And that's obviously a huge percentage. Probably with time and reasonable doses of it, you'll get 100% of patients. With the Mirapex or pramipexole, we will see 7 to 8% per year. And with the Nupro, that's the patch, it was only 5% after 5 years, although they used a little stricter criteria. And this was with the approved 1 to 3 milligram doses. And the question is augmentation really less common with a longer acting dopamine agonist? And here's what the issue is. One of the first and easiest signs to pick up of augmentation is an earlier onset. So the other drugs we use usually in the evening, and an earlier onset is easy to find because it starts occurring before you're giving the drug. But when you give a 24-hour patch like the Nupro patch, you are luckily blocking or hiding that earlier onset because you're treating it already. And many of us believe that you're just masking that earlier onset and the augmentation, and therefore kicking it down the road. So what we see now is that over 75% of referrals to national RLS experts like me are these augmented patients. And if you look, it's not hard to see, especially with Mirapex, which is one of the most common ones used. If it causes augmentation in 7 to 8% of patients per year, by 10 years, you've lost 70 to 80% of patients. Now I can ask everybody here, and I'm sure I know what the answer is. If I told you, hey, I have this great medication which works great initially to treat your diabetes, your high blood pressure, cholesterol, any disease, migraine headaches, I don't care what it is. It works great, but within a few years, and definitely by 10 years, the vast majority of patients are going to be much worse and much harder to treat. I think I'd have very few patients who would stand in line for one of those drugs. And that's why at this point, and this may change in the future, but right now, this is why we have knocked these drugs out of first-line therapy, and people like me rarely use these drugs, especially on a daily basis. So in fact, this is the paper that we published in 2021 in the Mayo Clinic proceedings, where we finally knocked out the dopamine agonist drugs as first-line therapy. But part of the reason why people like me still see, the vast majority of augmented patients is because even though, and even prior to this, we were already touting the fact that this shouldn't be first-line therapy, but this is, almost 3 years ago that this has been in the literature. If you look at prescriptions, new prescriptions for newly diagnosed restless leg patients who want medication, probably a minimum of 60-70% of the patients are still getting the dopamine drugs, and that's recent. So that's why we're still going to see a ton of augmentation for years to come. Again, the juxt of that algorithm is that the dopamine agonist drugs are no longer drugs of first choice for restless legs. And as I told you, I rarely prescribe them. I sometimes use them intermittently, but as far as on a regular basis, rarely do I ever use them, only when I have no choices at all. The alpha-2 delta ligand drugs are first-line therapy, and that includes regular gabapentin, Horizon, pregabalin, or Lyrica, which they're all listed here. Now, let me go over some dosing. And the red is what I'll attract your attention to here. So for Mirapex or pramipexole, if I'm going to use it, I start at the lowest dose, which is 0.125. And let me just say, especially when I have a patient who's older, and my definition of older has changed as I'm getting older, but we'll just say older for now, I will often even start with half of the initial dose, of the lowest dose that it comes. The maximum dose for the Mirapex is 0.5, and I can tell you, I see many patients who tell me, oh, their doctors just started them on 0.5 and then went up from there. If I'm going to use it, I virtually never exceed 0.25, which is half the recommended dose. And as you'll see later, I see patients on huge doses of these medications. Ropinirole or Roquip, the lowest dose it comes in is 0.25. And again, the max dose is 4 milligrams. I don't exceed 1 milligram if I'm ever using it. And the Nupro patch, start with 1 milligram. Sometimes they even start with half a patch. And the max dose is 3 milligrams. And I try to keep it to 2. If I'm really stuck, I'll go to 3, but I don't ever exceed that. And it does come in higher doses for Parkinson patients. Okay, so what do most other doctors and specialists, RLS, sleep specialists, neurologists, regular doctors, family doctors, what do they do for augmentation? So typically they think the patient is just having a natural increase in their restless legs, as I discussed before, and they'll simply increase the dopamine drug, which definitely provides improvement, although temporary. But the temporary improvement can be for weeks, months, or even years. And most doctors, when they get the feedback, they say, oh yeah, I did the right thing because my patient's better. And then they'll come back and say, oh, I need more because it may be better last time when you increase, and they'll keep increasing it until they feel uncomfortable. So I've seen the Mirapex be increased up to 10 milligrams. And remember, the maximum FDA approved dose is half a milligram. So that's 20 times the approved dose. The ropinirole, which has a max dose of approved dose of 4 milligrams, I've seen 24 to 48 milligrams prescribed. And the Nupro patch, which is FDA approved up to 3 milligrams, I've seen between 8 to 16 milligrams, and that's often in combination with Mirapex or Equip. So what do they then do? If they get a little nervous, they will often add the gabapentin, which is not a bad thing to do, but the trouble is once you get a patient who's augmented with high doses of the dopamine agonist, adding the gabapentin may or may not give some relief for a while, but the augmentation process, which is due to the dopamine agonist, will keep going. So sooner or later, no matter how much gabapentin you add, you'll either get side effects or you will not get any more effect. And many of them, if they're a little better versed in it, they'll add an opioid. And that will work pretty well. I see a lot of patients who've been given opioids, but they have to keep increasing the dose of the opioid because they're still on the dopamine agonist drug, which is driving the augmentation. So you can see what the issues are and why people like me see so many of these patients, because the treatment out there does not follow the guidelines, which I'm going to show you soon. So we published guidelines in 2016. We had a task force meeting and we came up with these guidelines, which look pretty complicated, but I'm going to go over them slowly and I will give you my take on all the different steps you can do. So the first thing we talked about is preventing augmentation is a lot easier than treating it. So if you don't treat with a dopamine drug, then you won't get augmentation and it saves a lot of trouble, but there are some patients who can't get other drugs or are sensitive to other drugs, and sometimes we are stuck. The other issue I see all the time, if a patient starts getting trouble with one short-acting dopamine agonist, Requip or Mirapex, their doctor will almost always change to another, and it is virtually guaranteed that sooner or later, usually sooner, they'll have the same problem with the other dopamine drug. So one of the things you can do is, if you are on a dopamine drug, keep the dose as low as possible. The augmentation occurs more readily with higher doses. And what I'm saying here is don't exceed the daily recommendations, which I've put there, and you saw my recommendations or my higher limits are much less than those because I really, really want to prevent my patients from getting augmented. And if they're having trouble early on low doses, that's when adding a non-dopamine drug may be helpful. The other thing is some doctors try to eliminate 100% of the symptoms. And I try to get close to that, but if patients have some mild symptoms, if they sit too long in the afternoon, I'm not going to worry about it. My main goal is to treat the late evening RLS when patients do want to relax and they don't want to walk around to get rid of their symptoms. And of course, the sleep or bedtime symptoms, because I want my patients to sleep. I'll put up with a little restless legs earlier in the day because those are easily taken care of by doing some activity. And that also lets you get by with less medication by not trying to overtreat. The other thing is you can use these medications, and I do often. I use intermittent treatment. one of the ones I use the most is the Cinemet or levodopa. You can use that up to 3 times per week with absolutely positively zero chance of augmentation. So even if patients have been augmented before, eventually I'll give them some Cinemet or levodopa, and I'll tell them you can use it as a rescue when you need it for whatever reason, up to 3 times a week. And this is not a drug holiday from the medication. This is just not using it on a daily basis, which will cause the augmentation. And we talked about longer acting dopamine agonists. Do they really have less augmentation? Or are we masking the augmentation because they're treating the earlier onset of symptoms due to their 24-hour effect? My thought is that we're just kicking it down the road. But I have had some success, especially if I can get away with the Nupro patch at 1 milligram, which is the lowest dose. If I have to use a dopamine agonist drug, that's the one I tend to use, and I try to keep the dose at 1 or 2 milligrams. And often if that does cause augmentation, it may be, many, many, many years down the line. The other thing is the iron levels are very important. The lower the iron levels, the better chance of people both getting augmentation and the augmentation being harder to treat. I have some of the old values here, 50 to 75. Some of the newer values are over 100. And frankly, I have lots of patients who I'll even get over 200 or 300 in order to get their symptoms better. But increasing your iron levels if you're augmented, it's unlikely. I can't say it's impossible, but it's not real likely that you'll be able to treat the augmentation even with a good iron infusion and getting your iron levels way up. I mean, it may happen occasionally, but I would say that's not going to be the most successful therapy, although it'll be very helpful. Okay, so this is the augmentation algorithm, which looks really complicated, but I'm going to go through it bit by bit. So the first thing is you want to eliminate exacerbating factors, and some of the stuff we talked about before, drugs, lifestyle, stress, things like that. Sometimes you can't. You want to get the serum ferritin or iron levels up as high as you can. Helpful, but it may not do everything. So mild augmentation is defined as just a time shift. A temporal means a time shift, occurs at least a couple of hours earlier. Your dopamine dose is still below the maximum. The symptoms don't cause a lot of distress yet. It's pretty early. And there hasn't been continuous increases. Usually this is the first time the patient wants an increase in medication. So the first thing we say, try to keep the dopamine agonist dose at the same dose. And the way you can do that is 2 ways. You can split the dose, give half of it the same time you did later in the night and half earlier to take care of the earlier onset, or you can give the whole dose earlier, which will take care of the earlier onset. Trouble is the medications don't last that long, and sometimes you may end up with the night. And it says here, if these options fail, you can consider 1 dose increase, but keeping it at below the daily approved dose that we talked about. I'm not as keen on this because once the patient is showing augmentation, they're going to continue to have it, and by giving them a little more, you just make it more difficult. You're kicking it down the road a little bit, and it'll be a little harder to treat the augmentation. It's much easier to treat it earlier than later. So my advice for here is, bite the bullet earlier than later. So if that strategy fails, we have a couple of things you can do. You can do a complete switch, and the first one is using one of those alpha to delta ligands, the gabapentin, Horizon or Lyrica. Sometimes that'll work if the patient is at a very small dose. Once you get to any significant doses, this does not work that well. And I will tell you, even with patients on a small dose, this can be pretty tough. And I'll talk about that a little later on the other side of the slide. The other thing you can do is you can change the patient to rotigotine, which is Nupro, or another long-acting dopamine agonist, as long as you keep the dose not too high. And again, this works really well, but it just may be kicking the can down the road, and eventually you'll have to treat them. But if you're stuck and the patient doesn't want to do some of the other treatments, or the alpha-2 delta drugs don't work, this is an option. And I sometimes even will use the rotigotine. But again, I warn the patient that we may just be kicking the can down the road and have to do something later. So if these strategies don't work, then we call it severe augmentation. So the object to treat the severe augmentation is to reduce at least, but in my mind, eliminate the short-acting dopamine agonists, or really all the dopamine agonists, and you can begin other treatments. So I'm going to go over the different treatments now. So one is, the yellow box here, is a cross titration with an alpha-2 delta ligand like gabapentin. And you kind of increase the gabapentin while you're decreasing the dopamine agonist drug. And what I'll tell you on this can be very hard. Every time you decrease the dopamine agonist drug, you're going to get a big bump in symptoms. And when you stop it completely, the symptoms are going to go really crazy. And often the alpha-2 delta drug just does not work that well. And we have studies showing that once you've been given a dopamine agonist, these drugs don't work that well. The next is a switch from a short-acting to a long-acting. We talked about that will symptomatically take care of the patient, but it probably kicks the can down the road. So then there's the treatment that they do at Johns Hopkins. It says 10-day washout. They're now on a 12-day washout. When you finally stop the dopamine drug, there's a 10, 12-day, 2-week period where the RLS goes into hyperdrive and becomes just really almost intolerable. Patients won't even sleep for most of that period. At the end of it, when the patient has washed out the drug and may be better, some of these patients may do better with an alpha-2 delta drug or an opioid, but from what I've heard, the majority of these patients still end up on an opioid. So you may end up where the last plan, which I'm going to mention, you would have anyway, but the patients have a 12-day kind of, horrible experience. The last one is what I do the most. In fact, most often I just go right to this. We stop the dopamine medication and we switch them to a opioid. We will treat them with iron as needed, but usually the big thing is switching from the dopamine drug to an opioid. So treating augmentation with the opioids, you can taper or stop the dopamine agonist. It really depends on the dose of the dopamine agonist. If it's real high, we'll taper. If it's not so high, I just go cold turkey. There's some concerns about DAWS, dopamine agonist withdrawal syndrome. I've given a talk before on that, and it's not related to how fast you taper the drug. It's not well defined, but it can cause withdrawal symptoms like with any drug that people get withdrawal from. And as I told you before, the RLS will get dramatically worse for 2 weeks, but you treat that with increased doses for the 2 weeks. And then at the end of 2 weeks, I have my patients taper down to find the lowest effective dose. And often it's a small fraction of the amount they needed initially. I may consider adding an alpha-2 delta drug, especially if the opioid dose goes high. And remember what I said before, preventing augmentation is much easier than treating it. So I recommend, and this is what I do, avoiding the dopamine agonist medications unless there's compelling reasons. when taking a dopamine agonist drug, keep it as low as possible. Don't exceed the recommended doses. And in fact, my doses are probably even more reasonable. Initiate treatment with one of those alpha 2 delta drugs. You can add a low dose of Nupro if needed, and that is a dopamine agonist, but keep it at the lowest dose, and add opioids if needed. So if those directions and instructions are followed, we should see very little, if any, augmentation. Okay, so that's the end of the talk, and I think we have some questions now.
All right. I thank you, Dr. Buchfuhrer. If you'd like, I can go ahead and get started with those questions.
Sure, why don't you go ahead?
Could medications cause worsening of RLS symptoms that don't classify as augmentation?
Okay, and we covered that a little bit in my talk, but clearly there's a whole bunch of classes of medications, almost all the antidepressants, the older antihistamines like Benadryl, anti-nausea drugs, anti-dizzy drugs, etc. There's a whole bunch that you have to make sure the patient isn't taking. And sometimes this is challenging because the patient comes in, I have a list of their medications that they've been prescribed, but I don't have the over-the-counter drugs, and there's a whole bunch of those in the list. And by the way, for all of you who are members of the foundation, you should have an RLS medical alert card that lists all those medications that worsen restless legs and alternatives that do not. So you can always look at those, and if you're not on any medications that worsen restless legs, then we don't have to worry about that being the cause of the worsening or possible augmentation.
Okay. Can augmentation be reversed, or will it always mean there will be a permanent worsening of symptoms and severity?
Okay. And there's a wide spectrum of what happens. It's hard to know whether we can actually completely reverse the augmentation and get back to baseline, because many of the patients have been on it for years, and it's hard to know whether there may have been a little natural worsening of the restless legs in the interim. But what I would see in general is that when the augmentation calms down by taking the patient off for a few weeks from their dopamine agonist drug, they get a lot better, but I would say the majority of the time they do not return to the baseline that they were at before they ever went on a dopamine agonist drug, which means they would probably end up needing more medication than they would have had they never ever been on a dopamine agonist drug.
How do you deal with the risk of augmentation in an RLS patient who also has Parkinson's disease? How do you manage it, treat it, all of that?
Okay, well, that's a very interesting question. The RLS patients have a different brain situation than the Parkinson patients. The Parkinson patients have almost no dopamine in the brain, but a ton of iron. The RLS patients have very little iron in the brain, but they have normal amounts of dopamine. So what we find is many Parkinson patients with restless legs can actually tolerate pretty high doses of even Sinemet, the carbidopa, levodopa, and Mirapex, and not get the augmentation. I'd probably say in my experience, because I have a lot of these patients, probably 75% don't get the augmentation. But for some reason, about 25% do. And then we're kind of stuck because sometimes they really need these dopamine agonist drugs, and the other non-dopamine agonist drugs for Parkinson's may not work as well. And you're kind of stuck, and sometimes we just have to treat around it, and it might mean we're using a little more of the other medications than we would otherwise. But strangely enough, the majority of Parkinson patients, we don't have to worry about it.
If a person is still augmented 2 years after discontinuing a dopamine agonist, is there a chance their augmentation will resolve?
Well, it's, like I said before, the augmentation is over, but the baseline has shifted to worse restless legs, and that'll stay like that indefinitely. So they're not, the really severe worsening goes away, and typically what you'll see is they may have had earlier onset, like in the early afternoon, and now it'll be early evening, but before they got augmented, it was only at bedtime. So they're still better, but they're not back to where they would have been if they'd never been on a dopamine drug.
Is there augmentation associated with Suboxone?
Okay, we get that question all the time, and the real question is there augmentation with opioids? Suboxone is a partial opioid, but it's an opioid. And my particular answer is no, there is no augmentation. Some of the RLS experts think that they may see some augmentation with some of the opioids, but my belief, my personal belief, is that it doesn't happen. And there's really what's going on is there's some other aggravating factor that may be hard to discern, like stress or something like that, that is occurring that is worsening it a little bit. But that's my personal opinion, and we don't have a strict answer. But in my experience of treating a lot of restless leg patients, I don't think there's augmentation with the opioids or the alpha 2 delta drugs or benzos, only with the dopamine agonist drugs and tramadol.
What are the most dangerous side effects of starting an opioid treatment?
Well, the most common side effect is constipation. And I have to admit, since treating with so many opioids, I've become an expert on constipation. And we actually, and especially people who've been prone to it before, I've had a few patients who can get bowel obstruction and have to be admitted to the hospital. But I will say, with a good preventative routine for that, we can take care of almost all patients, even the ones who've had pre-existing severe constipation. But the other bad issues we see, sometimes a small percentage will get severe depression. Some people with the longer acting opioids can get sedation that occurs even the next day, and they may have cognitive memory problems and just feel sluggish all the time. Interestingly enough, at the doses we use, we really rarely see this tolerance, dependence, and true addiction. And again, we're very careful. We try not to give, especially the regular opioids, to patients who've had an addiction history. And those of us who do this, we check urine opioid levels very frequently, and we monitor the patients well. And using especially drugs like Suboxone, which are almost impossible to overdose with, and really are not addicting, are even super less addicting than the regular opioids, we shouldn't have a lot of trouble.
How does one manage augmentation when there are no RLS specialists in the city? Where can my doctor get information regarding augmentation?
Well, that's an easy question to answer. They just have to join the Restless Leg Foundation, and they get webinars like this one. Plus, the foundation has a lot of literature that's readily available that the patient can read. They can even present to their own physician, and there's the RLS augmentation article and algorithms that you can. They're actually a free download. Carla, are they also available through the website?
We can give them to them. They're also in the medical bulletin, so we can
Okay.
pass that out, or we have the access to the open access articles as well.
Yeah, exactly. And if anyone wants to find them themselves, because these are open access, so you don't even have to pay for them. If you go on PubMed, which is PUBMED on the internet, you can search for these articles, and these ones are open access, which means you can just download them, print them, whatever, and look at them yourself and bring them to your doctor.
Right. So regarding supplementation for RLS and or augmentation symptoms, what is recommended, and does research show a difference in the recommended doses for men versus women?
For recommended doses of which, sorry?
Recommended, it doesn't say, does research show a difference in recommended dosages for men and women for, supplementation for
Oh, for
RLS?
supplementation. Well, again, there's, the only thing as far as supplements go would be iron, but the trouble is if you take oral iron supplements, it usually doesn't get enough in the brain to improve RLS in a non-augmented patient. And in someone with augmentation, even giving intravenous iron can reduce the augmentation, but probably is not going to reverse it. So there's not a lot you can do, and I don't think there's much of a difference, if any, in men and women as far as treatment goes in general.
Okay. Does having a low ferritin level cause augmentation to occur?
It doesn't cause augmentation to occur, but it makes augmentation easier to occur and get worse. So it just one of these things. You can think of it like this: there, if you're, if you have stress or low iron, the augmentation may come out quicker and worse, but the augmentation really occurs because of the dopamine agonist drug, and there are other factors that may make it more apparent or harder to treat. But uh, even though we do recommend supplementation, which is always a good idea with iron, if it's appropriate, that's only a partial treatment. The real treatment is get the person off the dopamine agonist drug.
Okay. So this is just some general questions we're kind of gonna lump together. We've had a lot of information asking about alternative therapies, and if you could talk about delta 8 THC, CBD devices, compression boots, socks. What about these alternative
Okay.
therapies? Are they effective?
Okay, so just in general, and it's easy for me to answer the marijuana THC stuff since I'm in California and we've had all these products more readily available than anywhere else in the country for a long time. What we know is that uh, the CBD does not help restless legs at all. It may help sleep, but not restless legs. The THC part is probably the part that helps restless legs. But if you want the THC or marijuana to help, it must be inhaled. It only takes 1 to 3 inhalations to get an effect, and it's usually within 5 minutes or less. And the reason why the inhalation works well is because it gets it into the bloodstream within seconds. So you get very high peak levels, which you can't do if you ingest it or take edibles. But the problem is it only lasts an hour or two because you get peak levels and then the levels go down. It's not helpful. I've had patients of mine use edibles that have them high for 24 hours with restless legs. Now, the next question was compression stockings and compression devices. They may work for a small percentage of people while you use them. There were some studies on the sequential compression devices given like earlier in the day, and they tend not to really be that helpful. But uh, anything that provides pressure may help some patients. A lot of patients don't like it. Uh, there was the vibration pad that unfortunately they're not making anymore called Relaxis, which was very helpful. So there's a bunch of non-medication things that might be helpful, as an adjunct to treat patients. The trouble is, when a patient is in severe augmentation, these only help mild to moderately and usually don't provide sufficient relief for a poorly augmented patient.
What about TENS units?
Okay, so John Winkelman at Harvard did a study with the TENS unit. I don't think he published it, but we've talked about it. And again, he was trying to use it earlier in the day. And uh, what he found was giving it earlier in the day, just like using the sequential compression devices earlier in the day, really made no difference. However, a few patients who could actually fall asleep with a TENS unit on uh, could, got relief of their restless legs and can fall asleep and felt that that worked. Again, if any of you have used a TENS, you know that it's uh, pretty bothersome, and most people can't fall asleep. And is it okay if I talk about the new Nidra device,
Please
Carla?
do. Yeah,
Okay.
we've gotten a lot of questions about that too.
Okay. So there's a new device that is very, very, very loosely related to the TENS. It's called Nidra, spelled Nidra. And what it looks like, uh, when it's a wearable, what it looks like is those tibial bands that runners wear under their knee when they have a little tibial tendonitis, which is common in runners. But it has a little electrode in that little Velcro band, and the electrode is right where the peroneal nerve is closest to the surface, and it gives a little stimulation to that nerve. Now the difference is a TENS unit really is meant to stimulate muscle and has huge voltages. This has a minuscule fraction of the voltage that a TENS unit has. And what it does is it's just trying to stimulate a nerve. So the sensation would be like a little buzz at most, not very bothersome at all. So what it does is by stimulating the peroneal nerve, it fools the patient's brain into thinking the patient is walking. Because when you walk, the peroneal nerve is one of the nerves that gets activated. So when we stimulate it while you're lying in bed, the brain gets an impulse that you're walking, even though you're just lying comfortably in bed, and that walking simulation of stimulating the nerve calms down the restless legs. Now, if someone is not augmented, I think they can get pretty good relief from it, and we have a bunch of studies on that. The question is, how does it work in an augmented patient trying to get off the dopamine agonist? No studies have been done on that. My prediction is it might help decrease the dopamine agonist a little bit, but that's a very challenging situation even for a device like that. We do have some studies that show you can get a 30 to 50% decrease in the opioid dose you're using, but that's when the augmentation is already over. Okay.
Okay. So 2 more questions. Can sleep apnea cause RLS?
Okay, that's a question that comes up quite a lot when we're treating restless legs. Um, and one thing I should say is I almost never get a sleep study on an RLS patient to diagnose or figure out the RLS, or even to see how many periodic limb movements they have or whatever. It really isn't very helpful at all to me. The only time I get a sleep study in a restless leg patient is if I suspect they may have sleep apnea. So the problem with restless legs is it occurs when patients are sleepy or drowsy during the daytime. If you have untreated sleep apnea, you're going to be more sleepy in the daytime, and that will trigger or provoke more restless legs. And I've actually seen many patients who we have diagnosed and treated for their sleep apnea be able to significantly reduce their RLS medication.
All right, we can't let you go unless you tell us some news in RLS, or if there's any thing that you're any research that you're participating in or looking to work on, or just any
Okay.
sort of news
Well,
that you can share with
yeah.
us.
Okay. Well, some of the new stuff is there's still people looking at that the blocker for that dopamine 5 receptor, the D5 receptor, that if blocked may enable us to use the dopamine, the dopamine agonist again, and we're all waiting with bated breath for that. The other thing that I'm involved in is the studies for that Nidra device, and we actually we're looking. We may even do a trial for patients who are augmented, although I'm not sure how that's going to work. But that's one of the trials we're doing. And the other thing we're doing in patients who get on the device, and let me just say it's been FDA approved a couple of years ago, but the insurance coverage is not great, like with any new device, and it's fairly expensive. But what we're doing for patients who are on it, we have a prospective study going to see how they're doing, looking in the future, looking prospectively in the future with time to see how they're doing. And we have a bunch of over a dozen patients already enrolled, and again, I'm the one involved in that, and I'm following them. And so far, we're getting some pretty reasonable results. But again, we need more time to see, is this durable? Does it work down the road? And those questions will take a while to answer.
Okay. Well, thank you so much, Dr. B. I know you've been in clinic today, and to come on and do a webinar. We're very thankful to you for all your time, expertise, and all that your work that you do on the Scientific and Medical Advisory Board for the Foundation.
Oh, very welcome. Love doing it.
All right. Well, thank you, everyone. And thank you for staying up with us, and have a good night.
Okay, I guess